This is A&P Live Studio. I'm your host, an RN and A&P instructor for advanced healthcare professionals. Today, we are going to explore the complex world of Kawasaki disease, a condition that really every pediatric healthcare provider needs to understand on a deep pathophysiological level. We're going to do this by following a patient's journey. And along the way, we'll connect the dots from those first signs of a fever all the way down to the intricate molecular battle that's happening inside the blood vessels. So let's get started. All right, let's begin with the case that will really ground our entire discussion. This is a scenario that you might very well encounter in a pediatric emergency department. So this is Kenji, he's 2, and his case is, statistically speaking, pretty representative. You see, Kawasaki disease mostly affects children under the age of 5, and we see the highest incidence by far in kids of East Asian descent, especially in Japan. So Kenji presents with this classic but really concerning group of symptoms. The absolute key here is a relentless, high-grade fever that just doesn't break with the usual fever reducers. And that's happening alongside a distinct rash, red eyes, and swelling in his hands and feet. Now, if you take these signs one by one, they might seem like a common childhood bug, but when you see them all together, that's a major red flag for a very specific systemic process. Okay, so let's get into it. To really understand what's happening on the outside with Kenji, we first have to see the invisible battle that's going on inside his blood vessels. Now, what's so fascinating about this slide is that it shows the core issue in Kawasaki disease, this systemic vasculitis. It's basically a case of mistaken identity, where the immune system launches an all-out attack on the body's own medium-sized arteries. You can clearly see that shift from a healthy, well-organized vessel wall to one that is just chaotic, inflamed, and completely losing its structural integrity. And this isn't just some simple inflammation. It's a progressive, multi-stage assault. It starts with what we call necrotizing arteritis, and that word necrotizing literally means tissue death. The immune system's first responders, the neutrophils, actually start destroying the vessel walls. Then the next wave of T cells and plasma cells arise, and they just keep that attack going. And finally, the body tries to heal, but this remodeling process called luminal myofibroblast proliferation can ironically cause even more harm by creating scar tissue that narrows the artery. That's a condition we call stenosis. And this diagram just illustrates the most feared complications so well. As those layers of the arterial wall get weakened by that inflammatory attack, they lose their elasticity. They just can't withstand the pressure of blood flowing through them anymore. So the vessel wall starts to balloon outwards, and that forms a coronary artery aneurysm, or CAA. And if you look at the progression here, you can see how this weakened, bulging area becomes the perfect spot for turbulence and clot formation, which can lead to thrombosis and, down the road, stenosis or even a heart attack. Now, let's connect this underlying vascular inflammation directly to the classic clinical signs that we're actually observing in a patient like Kenji. You know, every single external sign we see is a direct window into the systemic vasculitis. That bilateral conjunctivitis, it's not an infection, it's inflammation of the tiny vessels in the conjunctiva. And the classic strawberry tongue, that's a visible sign of mucosal vasculitis. Every clinical finding can be traced right back to this widespread inflammation of the small and medium-sized blood vessels. So here's the crucial point. Without treatment, up to 30% of children will develop coronary artery aneurysms. This single statistic is exactly why Kawasaki disease is now the leading cause of acquired heart disease in children in developed nations. Okay, so you're faced with this clinical picture. You understand the potential danger. How do you confirm the diagnosis? And maybe more importantly, how do our treatments actually work on a molecular level to stop this inflammatory process in its tracks? Well, the diagnosis is purely clinical. That means there's no single lab test that says, yes, this is it. We have to rely on a set of criteria: a high fever for at least 5 days, plus 4 of the 5 classic signs. A lot of people remember this by the mnemonic crash. Now, while they're not diagnostic, lab tests showing high levels of inflammatory markers like C-reactive protein, CRP, and erythrocyte sedimentation rate, ESR, definitely support the diagnosis by confirming that, yes, there is widespread inflammation in the body. So while the diagnosis itself is clinical, the echocardiogram is absolutely essential for assessing the primary complication. It lets us see the coronary arteries, and crucially, it lets us quantify any abnormalities using what we call Z-scores. By normalizing the artery diameter to the patient's body size, a Z-score gives us a standardized way to identify and classify aneurysms, which then helps guide how aggressive our treatment needs to be. The primary intervention, and this was a true breakthrough in managing this disease, is high-dose intravenous immunoglobulin, or IVIG. When we give it early, it is our single best tool for quieting that dysregulated immune response and preventing coronary artery damage. So how does IVIG actually work? Well, the exact mechanism isn't completely understood, but we think it acts as a broad immunomodulator. It might neutralize whatever the initial trigger was, it might turn down the production of inflammatory cytokines, or it could be directly suppressing the activation of the T cells that are driving the attack. Essentially, it just turns down the volume on the immune system's assault. But it's really important to know that up to 20% of patients are resistant and will need second-line therapies. So that brings us back to the big question, why Kenji? To really understand this, we need to zoom out a bit and look at the epidemiological and genetic factors that create the susceptibility to Kawasaki disease in the first place. I mean, just look at this chart. The striking variation in incidence across different ethnicities is powerful evidence for a genetic component. The rate in Japan is just orders of magnitude higher than in Caucasian populations, and that disparity holds true even in multi-ethnic societies like the United States. And that leads us to the prevailing hypothesis, which is that Kawasaki disease happens when some kind of environmental trigger, we still don't know what it is, but it's likely an infectious agent, encounters an individual who is already genetically predisposed. It's that combination that ignites the exaggerated and damaging immune response that defines the disease. And even though we focus so much on the coronary arteries, it's critical to remember that Kawasaki disease is a true multi-system vasculitis. The inflammation can be seen all over the body, from myocarditis in the cardiovascular system and sterile pyuria in the urinary system, to inflammation that affects the digestive and even the nervous systems. All right, let's quickly recap the entire disease pathway just to solidify all the key connections we've talked about. The whole process is really just a logical cascade. You start with a genetically susceptible child. Then, some immune trigger ignites a widespread vasculitis. That internal inflammation produces the clinical signs we can see and the hidden danger to the coronary arteries. And finally, that immune storm is controlled by early immunomodulatory therapy like IVIG. But this raises a really important question for the future. As children like Kenji grow up, we have to consider the long-term cardiovascular risks. Even when an aneurysm seems to resolve, that underlying vascular remodeling can lead to stenosis years and years later. This actually makes unrecognized Kawasaki disease a potential cause of premature heart attacks in young adults. As always, please remember this content is for educational purposes and is not a substitute for professional medical advice. Thank you so much for joining me today in the A&P Live studio. Stay patho-curious, and I'll see you in our next session.